Hi everyone. Today we are going to talk about vocal cord paralysis part 4. This is the final part of vocal cord paralysis. In this we are going to talk about unilateral complete palsy, bilateral complete palsy, the summary of all the vocal cord palsies that we talked from the beginning, and thyroplasty. What are the types of thyroplasty, etc. Now, what do you mean by complete palsy? Complete palsy is a term used when in this case, unilateral, one side, suppose for example, right-sided superior laryngeal nerve and right-sided recurrent laryngeal nerve are gone. There is some pathology affecting this. We can see this in some cases in bulbar palsy, where the patient presents because of many causes, but because of high blood pressure, patient may end up in CVA, cardiovascular accident. He may be having paralysis of one side, and that may be affecting the medulla. And then the patient is going to have in addition to many other palsies, patient is going to have palsy of the one-sided vagus, causing right-sided superior laryngeal and recurrent laryngeal nerve. So this is one kind of presentation that I can see, that we see in the clinic. Okay, unilateral superior laryngeal nerve palsies usually do not come to us. Bilateral superior laryngeal nerve palsies also, such kind of presentations are rare, but this is the presentation that we can see in our clinics. Bilateral complete palsy, where right-sided superior laryngeal nerve, right-sided recurrent laryngeal nerve, left-sided superior laryngeal nerve and left-sided recurrent laryngeal nerve, all the nerves are affected, all of them are gone. So when all of them are gone, what happens to the speech, what happens to the respiration, what is the management, etc. we are going to talk about. Now coming to the unilateral complete palsy, also unilateral superior and recurrent laryngeal nerve palsy, both one-sided superior laryngeal nerve, one-sided recurrent laryngeal nerve are affected, causing unilateral complete paralysis, So this is also called unilateral adductor palsy. Unilateral adductor palsy means inability of the vocal cord to adduct. So the vocal cord is in this position, also called a neutral position or cadaveric position, and it cannot come to the midline. That is called unilateral adductor palsy. Now coming to the understanding of what happens in superior laryngeal nerve and recurrent laryngeal nerve, one-sided palsy. One-sided palsy means, so coming to the sensory aspect, the entire nerve supply of the right-sided larynx, is gone. So there is no sensory innervation. Sensory innervation is not there. All the muscles which supply one sided of the larynx, that is cricothyroid and rest of it, like the posterior cricoarytenoid, lateral cricoarytenoid, intra-arytenoid, thyroepiglotticus or epiglotticus, oblique arytenoid, whatever. What are all the muscles that are being supplied by the recurrent laryngeal nerve on one side are gone. So what does it mean? It means that the adduction is gone, okay, abduction is gone, okay, and adduction, tension, tensor capacity is gone, and also relaxing. So all the functions of the vocal cord are lost. When all the functions of the vocal cord are lost, what happens? The vocal cord will be in cadaveric position. In cadaveric position means it is 3.5 millimeters from the midline. It cannot abduct, it cannot adduct. Because it cannot adduct, it's called unilateral adductor palsy, because bilateral abductor palsy is what we have given the name for bilateral recurrent laryngeal nerve palsy. Now this cord cannot abduct and adduct also. So all functions of one-sided vocal cord are gone. Where is the origin of the injury? Obviously it should be above the original superior laryngeal nerve. As we talked about, in cases of bulbar palsy, we can see this kind of presentation. In addition to other cranial nerve palsies will also be there. What is the position of the vocal cord? As I said, neutral, also called cadaveric position, that is 3.5 millimeters from the midline. What happens to the speech in this case? Now coming to this one, this is the right-sided, this is the left-sided. As you can see, the right-sided vocal cord is nice and taut and fine, and it is not in cadaveric position. It is like paramedian position. But you see the left-sided vocal cord, where left-sided vocal cord, there is a mild bowing of this left-sided vocal cord. There is a mild bowing of the left-sided vocal cord. Also, it has lost its luster also. So, and you can see there is a bit of if you can see this, the false cord, you can see the mild curve, and here also you can see curved or bowed of the bowing of the vocal cord. Okay, so this is left-sided complete palsy, where superior laryngeal nerve and recurrent laryngeal nerve are gone. Now what happens? The left vocal cord is not at all moving. The right vocal cord tries to move. It can come only to the midline. But even if it comes to the midline, 3.5 millimeters is quite a big gap. So the patient is going to have aphonia initially. Patient cannot speak. or he may have dysphonia or forced whisper kind of voice, because there is the other vocal cord. Other vocal cord is functioning normally. If the other vocal cord is functioning normally, the space is only 3.5 millimeters. With that, the patient can speak a little bit like a whisper. The voice gets wasted. The two vocal cords cannot come in the midline. So the voice is wasted. So the patient will have a dysphonia or a forced whisper kind of a voice. But as the other vocal cord compensates, this forced whisper improves and becomes hoarseness. Because not only the normal vocal cord will come to the midline, as the time progresses, it will cross the midline and try to come as close to the paralyzed vocal cord, It is curved, right? As close to the paralyzed vocal cord, and this causes hoarseness of the voice. So the patient can present with aphonia initially, then the patient may have dysphonia or forced whisper, and finally the patient is going to come with the hoarseness of voice. So there is improvement as the time is progressing. There is improvement in the voice. Aspiration, what can we say? Yes, it is present. Why? Because the right-sided superior laryngeal nerve is gone. Suppose in right-sided complete palsy, right-sided superior laryngeal nerve is gone. So there is anesthesia of the supraglottis. Okay, there is anesthesia of the infraglottis also. I mean, the glottis and the subglottis also, anesthesia is there. But this is more important from the aspiration point of view. The vocal cords are away from the midline and they cannot adduct, they cannot come close together. The cough will also be weak. So there are all the three components that are responsible to make aspiration happen. Okay, what are the three components? As we said, anesthesia of the supraglottis. Second one is there is a glottic gap, and third one, there will be a weak cough because the glottis cannot be closed perfectly. There will not be an airtight gap. Airtight gap will not be there. So aspiration is present. So this is one of the presenting features. It's not the main feature, but one of the presenting features, that cough is present sometimes because the other side is normal. It will try to compensate. The left vocal cord is also normal. The other vocal cord is also normal. So it will try to compensate. It will try to bring down the glottic gap as much as possible. Cough is ineffective. Now the one vocal cord is not at all moving and it's in a cadaveric position, 3.5 millimeters from the midline. So airtight closure will not be possible. So cough is ineffective as a vocal cord cannot close completely. Okay. So aspiration and cough will be present. Respiration's normal, no stridor. Stridor is present only in bilateral recurrent laryngeal nerve palsy where both the vocal cords are in the midline and cannot move away. Other than that, no other vocal cord palsy will have stridor as one of its chief complaints or one of its presenting features. Okay, so there is no stridor. Why? Because the vocal cord is already away from the midline. Suppose this is a midline, and this is already away from the midline. There is enough space for the patient to breathe, so the patient will not have any stridor. What is the management of this case? How do you manage this case? You have to bring this vocal cord, which is in a cadaveric position, which is away from the midline, back to the midline. So bringing it back to the midline is called medialization of the affected vocal cord. When you bring it close to the midline, you don't have to bring it perfectly to the midline. You can bring it a little bit close to the midline also, like para-median position also. The other vocal cord will come closer together and this will have a normal voice, and also the aspiration is prevented. So how do you medialize this vocal cord? How you bring the vocal cord to the midline? The first and the easiest procedure that is first thought of is injection of Teflon, collagen or fat lateral to the paralyzed vocal cord so that the vocal cord is pushed medially. So here we are seeing here this is the paralyzed vocal cord. You can see there is a bowing of the vocal cord here, and it's also away from the midline. Suppose this is the midline. Okay, this is away from the midline, and here they are trying to inject fat lateral to the vocal cord, Why? So that there is fat here and slowly it causes the vocal cord to come medially. So here they are saying, here they are showing a better picture. Here there is fat. The fat has been placed here lateral to the vocal cord. When you put fat here, even the arytenoid, the vocal process of the arytenoid is pushed medially. So the vocal cord comes closer to the midline. So this is called medialization of the vocal cord. So this is an easier procedure compared to others. The type 2 thyroplasty, this is also called medialization thyroplasty. How do we do this? We make an opening in the thyroid cartilage and we put a wedge-shaped silicone wedge which is present lateral to the vocal cord, causing the vocal cord to be pushed medially. Okay, this also causes medialization of the vocal cord, enough for the space to be that gap to be covered so that the other vocal cord will move towards the midline, and you will have voice, that is speech becoming normal, and also to prevent aspiration. These are the two goals with which we are doing the treatment. Laryngeal reinnervation procedure. Again, we have seen this in the previous one where we used ansa cervicalis. Here, the phrenic nerve is used to cause to provide some kind of laryngeal innervation to the recurrent laryngeal nerve. See here, the recurrent laryngeal nerve is transected. You are cutting the recurrent laryngeal nerve here. You are bringing the phrenic nerve and you are using it as a free graft in between this nerve and here where you want it to work properly. Recurrent laryngeal nerve abductor branch. Okay, so you're trying to provide some kind of laryngeal reinnervation procedure to the transected or to the recurrent laryngeal nerve that is not functioning, so that some kind of thing can happen. But this is not usually planned. Easiest thing is to inject Teflon or collagen or fat lateral to the vocal cord so that the arytenoid can be arytenoid is going to move, but the vocal cord is basically going to come medially. You can also do it by putting a wedge in the larynx. This is called, thyroplasties are always called, what are they called? Laryngeal framework surgeries. Laryngeal framework surgeries. That means you are going to work mostly on the thyroid cartilage. Okay, almost all of them. Then with this we come to the management of unilateral superior laryngeal nerve plus recurrent laryngeal nerve, that is complete palsy of one side. Okay, now coming to bilateral complete paralysis. Bilateral complete paralysis. What is bilateral complete paralysis? Right sided superior laryngeal nerve and recurrent laryngeal nerve, and left sided superior laryngeal nerve and recurrent laryngeal nerve, all of them are gone. Entire innervation, sensory and motor innervation of the larynx is gone. What happens in such cases? Both the vocal cords will be in cadaveric position and there will be no sensation at all of the larynx. So that's what he says. Bilateral adductor palsy, vocal cords are in cadaveric position, cannot adduct. It is also called bilateral adductor palsy. Both the vocal cords are in cadaveric position. Vocal cords are far away, cannot meet together. What is going to happen to the speech? Patient is going to have aphonia. Absolutely, he cannot speak anything at all. How do you differentiate this from functional aphonia? Functional aphonia is when a patient is going to come to you saying that, mostly females, young females in 16 to 18-year-old age group, where they say that the patient is not able to speak from the last 24 hours. He's not speaking at all. But when you ask the patient to cough, patient can cough. For cough, what is important? We said both the vocal cords should come together in the midline and provide an airtight closure of the entire lung. Okay, so that there is no air leak. Only then cough is possible. When cough is possible, then you say, yeah, boss, this is a functional aphonia. You refer the patient to a psychiatrist, or you can give counseling and get the patient out. That is great. But basically, reassurance to the patient's attenders is important. Aspiration. Now, aspiration, as we said, what are the three things needed? One is a glottic gap. Glottic gap is there. How much glottic gap? So much glottic gap is there. Suppose this is the midline. This is the vocal cord in cadaveric position on the right side. This is the vocal cord in cadaveric position on the left side. So there is like 3.5 millimeters on the right side, 3.5 millimeters on the left side. So what, 7 millimeters worth of glottic gap, and these vocal cords will not be able to come close together. So the glottic gap is huge. Okay. So second, anesthesia. Anesthesia of the vocal cords, anesthesia which is like supralaryngeal nerve giving anesthesia above the vocal cords and recurrent laryngeal nerve giving anesthesia below the vocal cords. Entire thing is gone. So there is no anesthesia. Is a cough possible? Cough is not possible because the vocal cords cannot come close together. So all the three things are there, and also they are present at its maximum level. Suppose there is unilateral, the left side will do some work. Unilateral, there is some anesthesia, some sensation present on the supraglottic area. Here, complete anesthesia is there. There's a huge glottic gap, and the vocal cords cannot come together to produce a cough. All this will lead to aspiration being a huge problem with these patients. Aspiration is the problem with which the patient is going to come to you. Okay. As I said, yeah, anesthesia of the supraglottis, glottic gap, leading to repeated attacks of bronchopneumonia. Why bronchopneumonia? Whatever food he eats will go into the larynx. He will be able to cough it through the larynx, through the trachea. He'll try to cough, but he cannot cough, and all that the secretions will go into the lungs, causing solidification and infection of the lungs, and the patient is going to have bronchopneumonia. That is the major problem with bilateral complete paralysis. Respiration normal. As I said, respiration is having a problem only in bilateral recurrent laryngeal nerve palsy. Other than that, no other case, no other vocal cord paralysis will have aspiration. Why? Again, because vocal cords are far away from midline, it is easy for the patient to breathe. Patient can take the air in, enough air can go in, enough air can. There is no problem with respiration. So how does the patient present to you? Aphonia. Patient cannot speak. This is a rare presentation. Actually, in so many years of my private practice, I have never seen a case of bilateral adductor palsy. I have not seen a case of bilateral adductor palsy. Both the vocal cords are not functioning. Maybe neuro, maybe they present to the neuro, but very rare that they come to the ENT. And the patient is going to present with chronic aspiration pneumonia. Patient is going to present with chronic aspiration pneumonia. This is the presentation. Aphonia and chronic aspiration pneumonia. Chronic means it is present from a long time, more than 3 weeks. Cough, as we said, there is inability to cough. What is the management aiming at? Aims at relieving chronic aspiration. So this is life-threatening for the patient. Life-threatening for it. It is not like he is going to have aspiration and he is going to be fine. No, the patient is going to have pneumonia, bronchopneumonia, and that itself will cause fever and shortness of breath and such kind of features. So this is what we are trying to solve. This is trying to relieve so that the patient can have a life at least. Okay. Now coming to what the management, tracheoesophageal diversion. This is called the gold standard of treatment for chronic aspiration pneumonia. How do you do that? You divide the trachea in between the second and the third tracheal ring. Suppose this is the trachea here. You have divided the trachea. The lower end of the trachea, you are bringing it outside and you are suturing it to the skin. The upper end of the trachea, you are suturing it to the pharynx. Okay. So now the patient has an airway. He can breathe properly from this opening in the stoma in the skin. He doesn't have a problem with the breathing anymore. Anyway, he didn't have a problem with the breathing. Now also he's not having a problem with the breathing. But now whatever is eating, whatever is going into the larynx, suppose this is the vocal cords here, it is going to the larynx, let it go into the larynx, no problem. It is going to go finally into the pharynx and into the esophagus. So there is no problem with the aspiration. It's not going to the lungs, right? So that is the major thing that we can do. So the food that he has eaten will go into the into this new anastomosis, from the new anastomosis to the trachea into the esophagus, and it will prevent aspiration. Once and for all, aspiration is prevented. This is a permanent procedure. We talked about this in bilateral superior laryngeal nerve palsy. We talked about epiglottopexy, where we took the epiglottis and we sutured it to the araepiglottic folds and arytenoids, and we prevented aspiration. We provided tracheostomy in that case. But that was a reversible procedure. This is a permanent procedure. You cannot reverse this procedure. This is a permanent procedure. This is done only in the case of bilateral complete palsy, where you know that the patient is not going to recover from this bilateral complete palsy. Okay, this is a gold standard, as we said. The upper end of the trachea, we said, yeah, this is voice is lost after this procedure. Voice is lost after this procedure because for the vocal cords to move, you need air to move. You need air, and between this, there is this complex interaction between this air coming out and the vocal cords moving. There's modulation, and the modulation, the speech also that is coming out of the vocal cords with the tongue, lips, all that. The voice has to go through the mouth and come out from the nose also. So this is what is speech. Okay, this is similar to total laryngectomy. We are not removing the larynx in this case. I'm just saying that it's similar to total laryngectomy, where the voice is lost in this procedure. So this is like the last resort, and this is the final step. When there is chronic aspiration threatening the life of the patient, you go for tracheoesophageal diversion. Tracheoesophageal diversion. So you are diverting it, trachea to the outside, and you are the remaining part of the trachea, you are diverting it into the trachea. That is what trachea is being diverted into. The trachea is being diverted into the esophagus to produce tracheoesophageal diversion. This is addition. This is tracheoesophageal diversion, and this is addition to the procedure. Now coming to epiglottopexy, just now I talked about epiglottopexy and vocal cord plication. These are temporary. These are like reversible procedures. You can do it either by epiglottopexy, where you take the epiglottis, okay, and these are the arytenoids, this is the vocal cords, and this is the araepiglottic fold. You take it back and you suture it to the araepiglottic folds and arytenoids to produce epiglotopexy. Or you can take the vocal cords and you can plicate it together to produce vocal cord plication, okay, or you can do vocal cord plication. When you have done this, the patient cannot breathe anymore. You have to add tracheostomy to this procedure so that the patient can breathe, and it's a reversible procedure. Okay, so this is the management of bilateral complete palsy. Bilateral complete palsy, superior laryngeal nerve, recurrent laryngeal nerve of both sides is gone. Vocal cords are in cadaveric position. Patient is going to present with aphonia and chronic aspiration. Chronic aspiration. Chronic aspiration is more of a problem. Is the problem, life-threatening problem. Life-threatening problem. So life-threatening problem, you are going to solve it with tracheoesophageal diversion. Tracheoesophageal diversion, or you are going to do epiglottopexy plus vocal or plus or minus vocal cord plication with tracheostomy, because you have to give some airway to the patient, right? So this is the end of all the palsies that we have covered from the beginning. Now coming to the summary so that you can remember everything, we'll have a small quick recap. Unilateral recurrent laryngeal nerve palsy, what happens? All the muscles of the larynx except the cricothyroid is gone. Cricothyroid is functioning. Cricothyroid causes the vocal cord to come to the median or the paramedian position. So the vocal cord is median, mostly median, sometimes paramedian. If it is median, speech will be normal. What are the various things we try to assess each palsy? Speech, aspiration, respiration, and management, and position of the vocal cord. Okay, if you can remember these 5 things, I think everything is done. 3, 4, 5. Position of the vocal cord, speech, aspiration, respiration, and management. Okay, what happens? You can't remember this. You can't like mug it and totally keep it in your system. It is not possible. If you can see the flow, what is happening, then everything becomes easy. Okay, unilateral recurrent laryngeal nerve palsy, all muscles of the larynx except cricothyroid is gone. Cricothyroid is spared. Okay, so the vocal cord will be, what does cricothyroid do? Cricothyroid is an adductor and a tensor of the vocal cord. So it brings the vocal cord to the median or the paramedian position. If it is a median, vocal cord will be normal. Paramedian, mild hoarseness initially because other vocal cord is there. It will it will cross the midline and give you good voice after some time. So what is the presentation? Patient will not even come to you or may present with mild hoarseness. Aspiration, there is no chance because there is no problem with anesthesia. Okay, respiration is normal because the other vocal cord is there and it is moving away for nice other vocal cord, the normal vocal cord, nice abduction is there. When there is no problem to the patient, what do? The treatment is conservative. Bilateral recurrent laryngeal nerve palsy. All the muscles of the larynx except the cricothyroid on the both sides are gone. Cricothyroid on the both sides, what do? They bring the vocal cords towards the midline because it is an adductor and a tensor. So it brings both to the midline and they cannot abduct now. So the vocal cords will be in median position. Speech will be largely normal. Sometimes there may be mild hoarseness. Aspiration will not be there, no chance because there is no anesthesia and also vocal cords are close to each other. This is the only palsy that presents with stridor and dyspnea. So this becomes life-threatening palsy. One-sided vocal cord lateralization is the management of this. Lateralization of the vocal cord, we said how do we lateralize? We can use the Thyroplasty type 2, okay, or we can remove the cord, we can do the cordectomy, we can remove either little bit of the epithelium, subepithelial, ligamental, the muscular can be removed, ventricle or the false cord, depending on the size that you want, the space that you want, you can remove. That is called cordectomy. You can use that, do it with the cold knife, or you can also use laser for this. And we have type 2 thyroplasty, that is called lateralization thyroplasty. What did we show? With the thyroid lamina, we cut it, right, and we produced we put a titanium splint to bring the vocal cords away from the midline. Okay, type 2 thyroplasty. Laryngeal reinnervation is there, okay, as described. What happens in unilateral superior laryngeal nerve palsy? Cricothyroid is gone. Okay, sensation is gone. If the cricothyroid is gone, what happens? It is an abductor. Other abductors are there. Abductors like posterior cricocarotenoid supplied by the recurrent laryngeal nerve. So the vocal cords will be moving normally. Only thing is this cricothyroid is a tensor of the vocal cord. So one-sided vocal cord will be bowing of one vocal cord. And the vocal cord cannot be tensed properly. So the patient will have weak voice fatigue, and loss of timbre will be there. The quality of the voice is gone. Okay, the loss of the quality of the voice is gone. Okay, so this is also not a major thing, but some singers can find it. Aspiration is present occasional. Yeah, here is say aspiration is present, occasional aspiration, because the sensation on one side is gone but cough is there, and also the vocal cord will move to the midline. The chances of aspiration are very less. Once in a while, you may have aspiration. Respiration, other than this, all other respirations are normal. So respiration will be normal, because other than a weak voice and loss of timbre, patient is not going to complain of anything. So conservative. So conservative here and conservative here. Okay. Unilateral recurrent laryngeal nerve, unilateral superior laryngeal nerve, they have a conservative management. What happens when there is bilateral superior laryngeal nerve palsy? Cricothyroids of the both sides are gone. Total anesthesia of the supraglottis above the level of the vocal cords. What happens? Aspiration. You think of aspiration is present. Okay. So what happens to the vocal cord position of the vocal cord? Both the vocal cords are bowed. Vocal cords are bowed. They can adduct, but they have lost the tensing capacity. So both the vocal cords will be bowed. Okay, the patient is going to present with husky voice. If you can remember this, bilateral superior laryngeal nerve is going to present with husky voice. Voice will be there, but there is husky. Why it will be there? Because the vocal cords can be adducted together. They will come together because there are other adductors like lateral cricoarytenoid. But the tensing capacity is gone. So bilateral superior laryngeal nerve will have a husky voice. Aspiration is present because both the sensation above the vocal cords is gone, but it is not severe. It is present. Okay, the respiration will be normal, no problem with the breathing, because the vocal cords can be adducted, can be abducted. They will go away when you breathe inside, when you take a deep inspiration. What is the goal of the treatment? To prevent aspiration. How do? You don't go for a huge procedure like tracheoesophageal diversion. You try to solve it by doing a tracheostomy plus epiglottopexy to prevent aspiration. Epiglottopexy, as we have seen, suturing the epiglottis to the epiglottic folds and arytenoids. Unilateral complete palsy. What happens in unilateral complete palsy? Superior laryngeal nerve is gone, recurrent laryngeal nerve of one-sided is gone completely. So what happens? One-sided vocal cord is not at all functioning. There is no muscle that can provide function to the vocal cord, and also anesthesia of one-sided larynx. So when the superior laryngeal nerve and the recurrent laryngeal nerve both are gone, what happens to the vocal cord? Vocal cord will be in cadaveric position. 3.5 millimeters from the midline. Neither will it if you ask the patient to take a deep inspiration, it will not move. If you ask the patient to say E and ask it to adduct, it will not adduct. Okay. So what is the speech like? Initially dysphonia can be there, aphonia can also be there. But as the time progresses, there is a normal vocal cord. Remember, there is a normal vocal cord. The normal vocal cord will bring it to the midline, will even cross the midline to give you some good speech, some understandable speech, to be using the right word, understandable speech. There will be some hoarseness of voice. Definitely, this problem we cannot solve directly unless we do a surgery, of course. So hoarseness of voice will be there. Aspiration will be present sometimes. Why? Because the left side will save him, the other vocal cord will save him, and also left-sided anesthesia is there. So aspiration will be present sometimes, similar to unilateral superior laryngeal nerve palsy. Okay, respiration will be normal. What the treatment of choice? You give a Teflon injection lateral to the vocal cord, so that the vocal cord is pushed medially, so that it is coming enough close to the midline. You don't cross the midline, definitely not. You bring it close to the midline so that the other vocal cord can come to the midline and give him a normal speech. That is our goal, right? And also to prevent aspiration. Voice also we can give him. Aspiration also can be prevented by simply injecting Teflon in lateral to the vocal cord to push it medially. Or you can do medialization of the vocal cord by putting a silicone wedge lateral to the vocal cord to push it medially. Okay. Bilateral complete paralysis. What is this? Bilateral complete paralysis. Both sided superior laryngeal nerve, recurrent laryngeal nerve are gone. Both the vocal cords will be in cadaveric position. They cannot adduct, they cannot abduct. So there is so much of space, making it a perfect thing to cause aspiration. Severe aspiration episodes causing bronchopneumonia, threatening the life of the patient. So this is going to cause this. What happens to the speech? Vocal cords cannot meet together. Again, they can never meet together. So there will be aphonia, and respiration will be normal because there is enough space. The treatment, the gold standard is called tracheoesophageal diversion, where you take the trachea, cut the trachea in between second and third tracheal rings. Lower part, you bring it outside to the skin so that he will have normal respiration, and you take the upper part and suture it to the esophagus. That is called tracheoesophageal diversion. So food that is entering into the larynx will enter ultimately into the esophagus. but the voice is lost in this procedure. If you want, you can do epiglottoplexy or vocal cord plication with tracheostomy also can be done. So this is a summary of all the vocal cord pulses. So we have 6 types of vocal cord pulses and we have noted them down. Now coming to thyroplasty. Thyroplasty are also called thyroid framework surgeries. They are divided into 4 types by Ishiki. You can remember it by medialization of the vocal cord, lateralization of the vocal cord, shortening of the vocal cord, and lengthening of the vocal cord. So you can remember it by the mnemonic men like short ladies. I hope you can remember this. Men like short ladies. M stands for medialization, L stands for lateralization, S for shortening, L for lengthening of the vocal cord. So I'll repeat again. Medialization is type 1, type 2 is lateralization, type 3 shortening, type 4 is lengthening. So they may confuse you like this. In NEET PG, basically NEET PG, they will try to confuse you. What is, suppose they will give you some clinical scenario and they will say, what do you want to do, type 1, type 2, type 3, type 4. Now that is where you will get confused. Just write medialization, lateralization, shortening and lengthening of the vocal cord. Men like short ladies. Okay. Now coming to this shortening and lengthening of the vocal cord. When do you do shortening? When do you do lengthening? This is a bit of a confusing topic. So let me make it as easy as possible from my side. So males usually have a low pitch voice. Understandable, right? Males usually have a low pitch voice. Females have a high pitch voice. For the vocal cord to be low pitch, vocal cord has to be lax. Compared to females, it is lax. It should not be tight. If it is tight, it becomes high pitch. So if you remember like this, males have a low pitch voice because the vocal cord is lax, and females have a tight vocal cord, so the vocal cord is tight. Vocal cord is tight. So what was I trying to say? Vocal cord is tight. So as compared to males. So if the vocal cord is lax, then you will have a low pitch voice. You can think of any chord instrument. If it is tightly strung, then what happens? It is tightly strung. The pitch will be more. If it is not tightly strung in between the two vocal cords, you will have a low pitch. So males have a low pitch, females have a high pitch. What is puberphonia? Puberphonia means a child, a male boy in the adolescent, he is growing up. A child has high pitch. Child has a high pitch voice. As he's growing up, it becomes low pitch. Because the Adam's apple, the thyroid cartilage becomes prominent, causing the space in between the arytenoid and the vocal cord to increase, and the vocal cord becomes lax. Okay, the vocal cord also grows. If the vocal cord doesn't grow, then it becomes a high pitch voice. So vocal cord also grows in length, and the male will have a low pitch voice. So we expect the males to have a low pitch voice. If a male is going to have a high pitch voice, it becomes a social problem for him. Androphonia, it is having the females having low pitch voice, females having a male voice. Puberphonia means males having a female voice or a childish voice. So how do you solve this? For solving this, we do thyroplasty type 3 and type 4. Puberphonia, what are we trying to do? We are shortening the vocal cord. Now there is 2 points of the vocal cord. Now they are like this, and puberphonia, it's a high pitch voice. So you are shortening the vocal cord. You are making the space in between the two vocal cords to come close together. Okay, to come close together. When it becomes lax or tight, vocal cord becomes lax. So it was tight initially, now it has become lax. When it is tight, it is high pitch. When it is lax, it becomes low pitch. So he will get that male voice. Okay, so this is done. Puberphonia, we do shortening of the vocal cord. That is type 3 thyroplasty, so that we can relax the vocal cord. We are not changing the length of the vocal cord. We are only bringing the 2 points closer together, so that the tight vocal cord becomes lax or loose, so that it can now function at a lower pitch. Okay, to give a male kind of a voice. And also in gender transformation. So let me just complete this. Puberphonia is, we do shortening of the vocal cord so that we can relax the vocal cord to give males having high pitch female voice a low pitch male voice. Gender transformation, you want to change a female from a male, from female to a male. Female was having high pitch voice, now we want a low pitch voice. Now we have done gender transformation, we change his voice also. Okay, from female to male. Okay, from a high pitch to a low pitch. Okay. Androphonia. Androphonia, what does androphonia mean? I said females having low pitch voice, male voice, low pitch voice, male low, females high. Androphonia, we do lengthening of the vocal cord. So we stretch it. Suppose this was the 2 points initially, now we take it further away, so that we are not changing the size, we are not doing anything to the vocal cord. We are just stretching the vocal cord, so that this was lax, now it becomes tighter. Tight means high pitch. High pitch means female voice. So we are changing a male voice to a female voice. So when do we do that? Females, initially females, they were having male voice, now we convert it to female voice. Or also in gender transformation from male to female. Male voice, he was having low pitch voice, but you want a high pitch voice. Okay, so androphonia, we do lengthening of the vocal cord. Lengthening of the vocal cord is type 4 thyroplasty, where you stretch and tighten the vocal cord to give females having low pitch male voice a high pitch female voice. So you are converting low pitch to a high pitch from a male voice to a female voice, done in androphonia. And in gender transformation, from female to male, male to female, male to female. Okay, you are transforming the gender of the person from male to female. So males have low pitch voice, you want to bring it to high pitch voice. You increase the length of the vocal, vocal cord, lengthening of the vocal cord. Why? Because you want to increase the tension. Tension, if you increase, you will get high pitch voice, female voice. So this is a little bit confusing. You may have to go again and again, so that it is understood to you. So with this, we come to the ending of the entire chapter of vocal cord paralysis, including thyroplasty. Thank you so much for the patient listening. Do subscribe and like the videos if you find it useful. Thank you.